Thank you. Thank all of you for joining. We're really delighted to be able to have this time to share with you. For those of you who saw this talk at the last meeting, this actually is a completely redone talk because there's a fair amount of new information on liver cysts. So I'm very excited about that and to show it to you. Let me just advance the slides. All right. This is me. I'm at Yale, and for the purposes of this talk, I'm also a member of the Scientific Advisory Committee for the PKD Foundation. All right. And what we will talk about today is PKD, but also a disease that's very similar called ADPLD, or autosomal dominant polycystic liver disease, and talk about how liver cysts form and also who's most affected by the liver cysts. And then a little bit about treatment, both surgical and medical treatment. And then I'll sort of wrap up with an algorithm for how we as clinicians think about managing those liver cysts. So the first thing is that liver cysts increase with age. So here what I'm showing you is how common liver cysts are. So in the first group, I'm showing you women, and then here in men. And you can see that by the time women are 25 to 34, about 90% have liver cysts. For men at a slightly older age, 35 to 46, about 93% of them have liver cysts. So very common part of ADPKD. And then what's really interesting is we're getting that if this is study data from very selected cohorts of people, what we're also able to show now is what the data is that we're getting from the PKD registry. And for those of you who participated in the PKD registry, you'll already be familiar with what some of those questions are. But 73% of the people in the registry reported that they had liver cysts, and about 34% reported that they had a diagnosis of polycystic liver disease. So again, more evidence that this is a very common problem with PKD. So the two terms sometimes get used interchangeably, but let me talk for a minute about what is polycystic liver disease. So a normal liver volume, meaning the normal size of an adult liver, is about 1.5 liters or 1,500 milliliters. And that gives us a height-adjusted liver volume of just under a liter per meter, or 940 mLs per meter. Assuming that the average height is about 1.6 meters. So liver enlargement is due to liver cysts, and most ADPKD patients have liver cysts, but about 10% have very severe polycystic liver disease, which means a height-adjusted total liver volume that's greater than 3 liters or 3,3200 ml. And then a small percentage of people, so 1 in 20,000, have severe polycystic liver disease, meaning such large livers that they're having complications. And that can be due to two diseases, either autosomal dominant polycystic kidney disease or autosomal dominant polycystic liver disease. And the umbrella term polycystic liver disease just means anybody with cysts in the liver, but the causes of that are one or the other of these two diseases. So what are these? So autosomal dominant polycystic kidney disease is primarily clinically diagnosed by having multiple cysts in the kidneys with large kidneys bilaterally. The liver may have a few or many cysts. And we know here that kidney size or total kidney volume determines the risk of progression. And 75% of patients will develop kidney failure by the age of 62. This disease is caused primarily by the genes PKD1, PKD2 or another rare one called GANAB. In contrast is the disease autosomal dominant polycystic liver disease. This presents with similarly with cystic enlarged kidneys and a cystic liver, but generally it's the cystic liver problems that predominate. The kidney disease may progress only slowly or not at all. So these folks with these genetic defects may not have much in the way of loss of kidney function. Kidney failure is rare. And the genes that are associated here are listed here. So ALG8, PRKCSH, SEC63, GANAB can cause both. So you see it listed twice, and then SEC61B. So how do these things, and then here's just a little bit about the genetics. So for the genes that cause ADPKD, it's about 10 people in 10,000 versus the genes that cause ADPLD, it's about 20 people in 10,000. So these genes, the ADPLD genes, are more common. And that's important when we're thinking about what of making an actual diagnosis for someone. It may be more common, but that it's not as clinically significant all of the time, meaning there may be people who have liver cysts who carry one of these genetic mutations who never come to clinical attention. And I'll show you some more of that. So how do these genes work together? So I'm showing you a simplified diagram of what happens inside a cell. So inside this cell, this is the nucleus that has the DNA, the coding information. And this is the place where all of the protein assembly and packaging happens. So a piece of RNA moves to this part of the cell, to the endoplasmic reticulum. And then it's interacted on by all of these different proteins that cause ADPLD. And these are like finishing proteins, if you want to think about it that way. They're adding sugar residues. They're sort of making sure that the protein is folding in an appropriate way. They're doing sort of those final quality checks. So the protein that's important here is polycystin 1, which is encoded by the gene PKD1. And all of these other proteins, the PLD genes, are making proteins that help that protein get appropriately packaged. And so you can see here that the end result is to get these proteins, polycystin 1 and polycystin 2, hooked up together and in the right place. And if that doesn't happen, then there are cysts that form either in the liver or in the kidneys. This is another way of looking at some of the things that cause liver cysts to form. So if you look here, there's this idea called ductal plate malformation. And here what's happening as the bile ducts where these cysts come from in the liver are forming, what happens is generally what happens is the cells start to form that cause the bile ducts to form. These cholangiocytes, which are the bile duct cells, grow and form a normal bile duct. And what's happening in these polycystic livers is that there's impaired maturation. The differentiation for those cholangiocytes to form in the first place doesn't happen well. And then that leads to these very abnormal and sometimes unconnected bits of bile duct. The other idea is that if you have a normal bile duct that has one gene that is disease causing, there has to be a second hit in that gene to knock out the gene, both copies of that gene. And when that second hit happens, that's when cyst formation starts. So this idea of second hit is important both in kidney and in liver cysts, but here showing you the pictures in the bile duct, that when that happens, there's abnormal growth of those bile duct cells and then the cysts form. And all of these different mechanisms then lead to polycystic liver disease. And then this is just showing you graphically what I mean by that. So this is now what you're seeing is the liver here. These are in the green is the biliary system, the system that makes bile acid. And what you can see is someone with mild disease may have a few cysts. And then as those cysts grow, this is someone with more advanced disease. And then this is someone with severe polycystic liver disease. And here, this is just showing you by imaging that you can't really tell by imaging always what the patient has. So this is someone who has isolated polycystic liver disease from a mutation called PKDCON. And the image I'm showing you, this is the liver here. And all of the darker spots in here are liver cysts. So all of these things in here are cysts within the liver. But you can see here is the kidney, and the kidney looks really good. There are not very many cysts in that kidney at all. So that is telling you that this is more likely to be in a disease that causes ADPLD. Versus here, you can see someone who has PKD, autosomal dominant PKD, and they have multiple liver cysts with a very, very enlarged liver. And if we saw their kidneys, you can see there's one kidney cyst here, and we would expect to see more kidney cysts as well. So knowing that liver cysts can be due either to ADPKD or to ADPLD, we then tend to treat the patients who have liver cysts in the same way. So one thing that's very important if you have liver cysts to know is that the tests that we use to measure liver function, called the LFTs or liver function tests, can be abnormal. And this is just looking at baseline values of people who had liver cysts and what those liver function tests look like. And what's important to know is that some of the common liver function tests, so bilirubin, alkaline phosphatase, or GGT, may be elevated at baseline. And some of the cancer markers that associate with the liver may be elevated at baseline as well. So CA19-9 may be elevated in up to 45% of patients without proof of malignancy. But the important thing is in PLD, liver synthetic function remains intact. So even though you might have mild liver function abnormalities, the work of the liver, the sort of cleaning the blood, detoxifying everything, that still remains intact. And there can be minor abnormalities in other liver function tests, in AST, ALT, and then in an enzyme made by the pancreas called amylase. And this is some of the new data now in looking at liver cysts and thinking about liver cysts. So a very big study that came out recently saying, well, can we start to quantify and look at how quickly liver cysts grow? So this is a baseline study with 245 patients who had liver cysts out of this larger group of about 700 patients. And what you can see is that liver cyst volume, so the volume of the cyst growth, is about 20% per year. And then if you look at liver volume growth, that's about 2% per year. And who are those people that are getting these increases in liver cysts? So what we know is that there's a higher baseline liver cyst volume in women, and that liver cyst growth rate changes in women after menopause. So this is the first hint that liver cyst growth may be responsible, that estrogen may help cause liver cyst growth. But otherwise, you can see that there's a higher rate of growth in men compared to women. So what are those things that actually did not really seem to impact liver cyst growth? So BMI did not, genotype, whether they were PKD1 or PKD2, did not, and then baseline total kidney volume did not. So these things which are very, very important for kidney volume measurements are not important for liver volume. The liver volume seems to be responsive to other things, including maybe to estrogen. And what they did, and this will look very familiar to those of you already used to thinking about kidney cyst volume. This is looking now at liver cyst volume. So saying that based on the liver cyst volume and the rate of growth of those liver cysts, we can now start to identify people who are at very high risk of liver cyst growth versus those people who are at lower risk of liver cyst growth based on what their curves have been over time. And now this is a different study, an older study, and this is looking at what are the differences in those patients who have mild polycystic liver disease versus those patients who have severe polycystic liver disease. And the patients with the more severe polycystic liver disease were older. So here 42 versus 35. They had more loss of kidney function. So the GFR, or the glomerular filtration rate, in those with mild disease is 95. In those with the severe disease is 84. They had similar sized kidneys, but had larger spleens. And importantly, they had only minimal reported worsening of quality of life, which is critical. So older, more likely to be women with some loss of kidney function were those who had the more severe disease. So the next few slides are going to talk about estrogen and the role of estrogen in the liver cysts. So this is a very small study from 1997, and they looked at women who had severe polycystic liver disease, and 8 women were controlled women, 11 women got treated with Premarin. At the time, most women got treated with hormonal therapy after menopause, so this wasn't unusual treatment. But what was unusual is that the kidney and liver volumes got measured after 1 year of treatment. And what you can see is after 1 year, there's a clear increase in liver cyst volume and in total liver volume in those women who got hormonal therapy. So based on this study, the literature, and we all started to say that young women with PKD should avoid estrogen-containing birth control to minimize the risk of liver complications later in life. But this study was in 1997, and clearly a lot of time has passed since then. So I want to show you some of the more recent data after that. So this is looking from the HALT PKD study, and this is looking at height-adjusted liver volume, and then looking at the percentage with liver cysts or their size of livers, either for patients who were never pregnant and never used oral contraceptives, or used oral contraceptives, or then had pregnancy. And then here you can see it's at 1 versus 2 pregnancies. And what's important here, oops, I'm sorry, is that there was no different in the height-adjusted liver volume with oral contraceptive use. Women who had pregnancy had larger kidneys, but that was due to them being older. And so when they adjusted for age, that difference went away. And since then, there have been multiple publications that show no association between the use of estrogen-containing contraceptives and total liver volume or total liver cyst volume. However, this is now another study that came out in 2019, and what they found was for each year of oral contraceptive exposure, there was about a 1.5% increase risk of a higher total liver volume. And that again here, pregnancy is not associated with a change in liver volume. So based on this, my practice is to make this a patient-centered discussion. Clearly, if I'm talking to a young woman that's in that category of the very severe liver disease, that's about 10% of patients, then all of us would counsel not to give estrogen-containing therapy. But somebody else who has very mild disease, it may be appropriate for them to have some estrogen-based therapy once that conversation and sort of the risks and benefits are understood. And this is a study that is just getting started. So it's called Against PLD. And the idea here is that if estrogen permits liver cyst growth, can blocking the sex hormone production be used as therapy? So this is a study in which 36 premenopausal patients with very large liver volumes are being recruited, and they're giving leuperoline, which is, some of you may know, is Lupron, which is used for treating prostate cancer. And what it does is it blocks the hormones that then lead to estrogen and progesterone release. And with the idea of seeing if you give this, will that slow down liver cyst growth in these young women who may have an estrogen-related growth in the cysts. And then they're doing some safety data here, some bone scans and some patient questionnaires as part of the study. So the next few slides are going to now talk about therapy. Here I'm showing you a picture of one of my patients. This is an MRI. So this is a section where you're looking, her kidney is here and her liver is here. So she has a very, very large cystic liver and also has large cystic kidneys. And here, this picture that I'm showing you, which is the cross-sectional picture, is just the picture showing you all of her liver cysts. So she has large total kidney volumes, but also a very, very large total liver volume of almost 9 liters. And she has some renal insufficiency. Her creatinine at the time that I took this picture is 1.8. And you can tell she's very thin. There's almost no fat there between where these cysts are and where the outside is. And you can feel her cysts very easily in the upper part of her abdomen. And she asks about therapy, about treatment. So this is to show you that the symptom burden changes with liver cysts as the liver cysts get more severe. So in the blue are patients with mild liver disease, and in the green are those patients with severe liver disease. And as the liver cysts increase, patients are complaining of fullness, of dissatisfaction with the abdomen, of tiredness, of limited mobility, of pain and pressure under the rib cage, of something we call early satiety, which just means you feel full after a little bit of food, but not having eaten the full amount of food that you ordinarily would. And then when they looked at physical component scores of well-being or mental component scores, with the severe PLD, there was a clear decrease in those physical component scores, but not in the mental component scores. And just more so the complications people can think of as the liver cysts are getting bigger and bigger. And so this cartoon diagram at the bottom is just showing you here the lighter tan is a liver cyst. And then here there are more liver cysts here in this part of the liver, here more cysts here, and then this liver is completely taken up with cysts. So people notice back pain, flank pain, abdominal fullness, anorexia, loss of appetite, palpable masses. A lot of these things can be very common. And then looking back at the PKD registry again, what are we seeing there? So about 78% of patients reported seeing a nephrologist to manage their liver cysts. And I am a nephrologist. I see a lot of patients regarding their liver cysts. Only about 8% see a liver specialist. What do people report? So 27% said they report feeling full after eating. 30% said pain or pressure near the rib cage. Feeling bloated, having abdominal pain, having limited mobility, meaning difficulty reaching down or bending over. And 14% said they were short of breath. About 43 had been told that their liver was larger than average, and about 58% had a family history of liver cysts. So what are the complications of liver cysts? As with any cyst, we worry about cyst hemorrhage, so bleeding into a cyst. A cyst can rupture or it can get infected. And then again, looking at the registry, about 6% reported a liver cyst infection, 10% reported a liver cyst rupture, and 9% had a liver cyst drained. So this is an image, this is something called a PET CT scan, where they do the CT scan and then they give a certain kind of tracer that lights up in metabolically active areas. So, and that looks like this orange color here. So you can see the spleen is lit up because the spleen is metabolically active with all of the white cells there. And then here you can see in this part of the liver that looks like this orange halo surrounding a cyst. That orange halo is all the inflammation from the infection in that cyst. So liver cyst infections are rare, but they can be life-threatening. So anything, so fever or really severe abdominal pain might be an indication of a liver cyst infection. And this is really to teach the other providers that when you're treating a liver cyst infection or any cyst infection, you need to use an antibiotic that penetrates into the cyst cavity. Pain is also very common because of those liver cysts. So what do we do for pain? So I think the first question with pain, is it related to PKD? Is it not? Are there non-pharmacologic ways of treating it? So behavioral modification, physical therapy. And then what are those pharmacologic ways of treating it? And then we start to talk about minimally invasive therapies. Here for liver-related pain, they talk about splanchnic nerve block, which is blocking the nerve so that you're not aware of the sensation of pain. And then other invasive therapies would be cyst fenestration or even removing part of the cysts, the liver, and I'll show you what that looks like in a minute. So this is just showing you where those different nerve roots are that either are part of the celiac plexus or are part of what gets blocked for renal nerve studies. And so this is a potential area of therapy, of doing nerve blocks to help manage pain. This is the other potential therapy. So here I'm showing you a picture of the liver with the cysts in this tan color. And so you can put a needle in, the radiologist will do this and pull out fluid. That's called cyst aspiration. And then sometimes they'll put in foam or alcohol or something else that causes the tissue to then sclerose or scar down around the cyst. So the cyst doesn't reform. So this is aspiration and sclerosis. Then there can be fenestration, which just means to make little holes in this so the cyst can sort of drain out into the abdomen. So that's what this is showing you here. They're just cutting open a cyst and letting it drain into the surrounding belly. So how well do these work? Unfortunately, they're not 100%. So after someone gets cyst aspiration with sclerosis, there's regression of the cysts in about 22%, and total regression in 22% and partial regression in 19%. So somewhere in the order of 40% of patients are getting some relief, but that means that 60% of patients are not, about half are not. The cysts recurred in about 20% of patients. The symptoms improved in the majority of patients, so that's the good news. And continuing regression, so it may take up to 6 months for a complete improvement following that procedure. And I've had patients where we'll look and see if they have some dominant cysts, we'll do some aspiration and sclerosis, and then a year or two later, they may come back because now there's something bothering them again, and we'll go through that procedure again. Where the cyst is determines the best kind of surgical therapy. So if you have this picture where you have one large cyst here, then that would be appropriate for cyst aspiration or sclerosis. Here you can see one lobe of the liver is really affected, whereas the other one looks very normal. And so that might be an appropriate candidate for taking out that cystic part of the liver. And here, this is a picture that looks more like the picture of my patient that I showed you, where the entire liver is taken over by cystic disease. And this is someone that might then go to liver transplant. And just to remind you, this is the rare patient with severe disease that's going to go to liver transplant. There are excellent long-term survival following either partial hepatectomy, meaning taking part of the liver out, or with cyst fenestration. So really we're looking at survival up to 25, 30 years. That looks very good. And then you may have heard that there are exception points for people who have very large livers who are trying to get a liver transplant. And these guidelines were updated, in 2021. So it had to be, previously it was having the very, very large cystic liver plus being on dialysis. And now that's changed. So if your GFR is less than 20, you can get the MELD exception points, or if you have evidence of liver failure or you're on dialysis. So very big liver plus evidence of some significant kidney disease, and you can qualify for these MELD exception points because otherwise the points for who gets the liver transplant is based on how much liver failure there is. And in PKD, there isn't liver failure per se, but there's just a space occupying problem from having a very large liver. And so this is to try and level the playing field a bit so that patients with PKD or PLD also still qualify in a reasonable way for liver transplants. That's what these MELD exception points are. So what are the outcomes after liver transplant? So this is from another recent study, 51 patients who underwent liver transplant, either with polycystic liver disease or with ADPKD. In their 50s and 60s. They followed these patients for about 6 years, and the survival was actually excellent, which is really, really encouraging. So this is a huge surgery, but people do well, and that's good. What about medical treatment for patients with large cystic livers? And so here I will show you what the medication is in a minute, but this is someone on treatment. And you can see this cyst got better over time and still looks pretty good over time here. But not everyone has a robust response. So if you look at this patient down here, patient 3, you can see that this person throughout the course of the treatment, although they have a response, it's a little bit soft, right? They're still ending up with a liver volume that's over 7 liters. The response to this therapy is highly variable. This is with octreotide or an octreotide analog. And the side effects include loose stools, increased blood sugars, and an increased risk of gallbladder disease. So octreotide and somatostatin, these are the different names for the same drug. Somatostatin is a GI hormone, and octreotide is just a name for that hormone, a medical name for that hormone. And so they pulled the data from all of these different studies with somatostatin or octreotide to come up with a sense of who are really those people who benefit from the medical therapy. And what they found was that the therapy was most effective in young women under the age of 48, so the premenopausal women. One of the liver function tests, alkaline phosphatase, may predict who responds and who doesn't. And some studies suggested that although liver growth resumes, there may be a lasting benefit after you stop the medication. So it may still be worth trying. And I think that, the idea here is if someone is very much bothered by the liver cyst, to try the therapy for 6 months, and if there's no improvement after that, to stop treatment.
Dr. Dahl, we are at 10 minutes.
Okay, and I'm nearly done. So this is a slide showing that for people who have had kidney transplant, there's a drug that is not used as commonly anymore, but had been used fairly commonly before, sirolimus, that seems to have some benefit in reducing polycystic liver volume after transplant. And so for this patient, the treatment would be at the beginning to talk to her about estrogen use, to consider conservative therapy, to consider aspiration and sclerotherapy, or laparoscopic fenestration, or liver transplantation. And then if she's not a candidate for liver transplantation, then to consider the somatostatin or octreotide analogs. And my final slide is just to show you that there's always work in progress. So this is work showing you all of the different areas that people are looking at for potential therapy. So hopefully a lot more to come. And I'm going to just show you a couple of studies that are ongoing now. So this is a study by Whitney Bessie, who's at Yale with me, and she's looking at for genes that cause liver cysts. And so if you have liver cysts or are interested in this study, then she would love to hear from you. And one more study for people associated with Yale. This is now looking for another kind of PKD complication called a cerebral aneurysm. So if you have a cerebral aneurysm and are interested in participating, please reach out to us as well. And then finally, I'm wearing my PKD Foundation hat and saying, if you haven't looked at it already, then please take a look at the PKD registry, because we would love to hear from you within that registry. And this is how to contact me. It's neera.dahl@yale.edu. And then with that, I'm open for questions if anyone has questions.
Fantastic. Thank you, Dr. Dahl. Yes, I do have a couple already. So let's start with, is there any relationship between polycystic liver disease and gallbladders, risk of gallbladder disease?
Oh, so that's a really interesting question. So I didn't point it out, but the gallbladder is part of the biliary system. So the gallbladder is where bile acids get stored. And so you can imagine that there isn't a direct connection and that cysts don't form in the gallbladder, but you can imagine if you have a very cystic liver that might be putting pressure on the gallbladder or impairing the full emptying of the gallbladder. So I would say it's not a direct relationship, but there could be a relationship there.
And what about the what kind of contraception would you recommend to someone who has PLD? You know, you mentioned that estrogen can increase risk factors. There's a specific question about estradiol as well. If you could comment on that.
Yeah, so in general, we recommend low estrogen. So there are some progesterone only contraceptives or very, very low estrogen contraceptives that we would tend to favor. I had a patient who was in, and I said to her, what about a diaphragm? Like, you could think about that. And she looked at me like I had lost my mind, like that was such old-fashioned therapy that people didn't think about that anymore. But, you know, I think any of the non-hormonal therapies or non-estrogen containing progesterone therapies would be very
I don't know how to make it stop. There I go. Maybe.
So we're going to check in here, right?
Well, I want to change my clothes.
I'm going to just do a quick mute.
okay.
And then I have to unmute you, Neera. So if you just go ahead and unmute yourself.
Yes, all right, there we go.
No, I muted everyone because I couldn't figure out the
Okay.
button. So another question is, could you speak to any nutritional therapies or recommendations that you give your patients for what might be beneficial for PLD?
So this is I think an area that's very, very important. We're learning for kidney cysts that diet matters a lot, right? So for kidney cysts, we're saying be careful of a high salt diet, eat a high potassium, sort of high fruit and vegetable diet if your kidney function is normal, and be careful of very high sugar, because we think that cysts preferentially use glucose as a fuel source, and so we know that if sugar levels are too high, that might potentially lead to an increase in cyst growth. So that's the kind of dietary information we're talking about already for PKD. We don't have that same richness of data for what is the right diet for liver cysts in particular. But I think a lot of those things that we think are important for kidney cysts are probably very good. I know some of my patients who have early satiety or get full early, the key for them seems to be eating more frequent meals, but smaller meals. And that seems to help with some of the symptoms as well. So I would say to follow what we say for the PKD diet, but then sort of to modify it in a way that seems to be comfortable with having the liver cyst issues.
We have a few questions here also about the pancreas. Do you have any comments on pancreatic cysts, or perhaps what may happen to the pancreas if the liver is enlarged and pressing on the organ?
So I did not mention it at all, but having pancreatic cysts is actually part of PKD, and it's not uncommon for people to have pancreatic cysts as part of PKD. It can be a little bit complicated, because when the imaging comes back that shows the pancreatic cyst, there's a kind of an early precursor to cancer that can also look like a cyst in the pancreas. So sometimes people with PKD will be asked to get follow-up scans because they want to be very carefully looking at these pancreatic cysts. In terms of, so the pancreas has a big role in secreting fluid and bicarb and things like that into the digestive tract. And that is usually completely intact in patients with PKD. But I can imagine that there could be cases where there's a cyst in the pancreas that's impairing some of the pancreatic duct flow. I haven't seen a case like that, but I can imagine that some people might have complications with that.
Is there anything specific that post-kidney transplant patients should know? We have a question about tacrolimus or any other medications that might influence PLD.
So the only post-transplant medication that we know of is the sirolimus or rapamycin, which seems to improve PLD, seems to decrease liver cyst growth. Tacrolimus and the other medications don't seem to really change liver cyst growth. We know that liver cyst growth continues after transplant. So it's we've had patients where the kidney is working perfectly, but there are complications related to that enlarging liver. But luckily that turns out to be the minority of patients. And the same things that are available pre-transplant. So fenestration, aspiration, hepatectomy, all of those things can happen after transplant as well.
Great. And if there were one or two questions that you would urge patients to ask their doctor if they know they have liver cysts, what would those be?
I would say don't just think that this is normal, that you have to have a certain amount of abdominal pain or you have to kind of just manage that. I would say if you're uncomfortable, have a conversation about that and see if there's something that can be done about that. For those patients who have a predominance of liver cysts but don't have a lot of cysts in the kidneys, that could be that other disease, ADPLD. And so I would ask for genetic testing if you're not sure of the diagnosis. I think that's a reasonable thing to ask. Now we have pretty good access to genetic testing, and a lot of those things can be sorted out. So that might be helpful. But I would say There are therapies, the places where they offer therapies are in relatively specialized medical centers, but if you think that that's what you need, to really ask and see if that's available for you.